Okay. So dizziness is a very common symptom. So now I thought I will address some common problems in these few weeks. So I have chosen that symptom. Sometimes we find it very difficult to understand why somebody is dizzy. So we will have a template how to approach such a patient. Still 20 to 25% of patients, we don't know why they are dizzy. So these are my grandchildren. So, okay. So dizziness is a subjective feeling of maladaptation with the environment. It forms a it's not a specific disease like epilepsy or brain tumor, nothing like that. So it's a subjective feeling of maladaptation with the environment. It forms a heterogeneous group of disorders, but it is a cause for public health concern because disability adjusted life years suffer. They take leave and people's quality of work becomes affected, even though it's not a serious disease. That way, this is very important. So what is that disease complaint? It is also a large group of symptoms like lightheadedness. We don't know what is lightheadedness. We know that our brain weighs about 1.5 kilograms, which is slight mild difference between the genders and races. But when it floats in the CSF, it weighs only 50 grams. So that we are able to walk comfortably with 1.5 kilograms on top of our body. And large sinuses reduce the skull weight. So brain weight is reduced by the CSF and skull weight is reduced by the air sinuses. And so we are okay. So beyond that, what is that lightheadedness? Neither the patient can explain nor we will be able to understand. And some people tell feeling like fainting. Is it pre-syncope or is it having the ulcerogenic, adrenergic, neurogenic phases of a syncope? So nothing is there. And then they will tell subjective imbalance, nothing objective. So these are the various group of complaints patients come with. And it's very difficult for us to choose an investigation or choose a treatment option. So we ask some standard questions. Is my patient suffering from vertigo? In which case we can easily treat that. Is he suffering from a pre-syncope condition? Then look for causes of syncope. There may have adrenergic features like palpitation, sweating, nausea, blurred vision, flightless. And if those symptoms are there, we will decide, okay, this is pre-syncope or syncope, and we'll evaluate the patient for those causes. So that is palpitation, sweating, nausea, blood vision, and flightless. And is it ataxia? Subjectively, he feels very much imbalanced, cannot walk, but others do not feel it. So we have asked so many questions when walking through narrow paths or when in the darkness. Is he swaying to either side? So those questions will help us to know whether it is a subtle ataxia. How is he managing the turns? When we suddenly turn, subtle imbalance becomes obvious. So the subjective symptom can be explained on such basis. Then is it not organic? Many times it may not be organic at all. That may be the reason why patients are unable to give a detailed history of what they are going through. Then hyperventilation syndrome, anxiety related patients hyperventilate after their carbon dioxide washes out and patient becomes dizzy. And there are unknown causes which remain to be understood. So these are the questions. Then what is that balance and what is equilibrium? Balance is ability to maintain stability during stable standing. So when you are standing, are you steady? That is balance. What is equilibrium? Is ability to remain stable during standing and walking. So the equilibrium is dynamic. Balance is static. When you are standing, if you are steady, you are in balance. When you are walking, if you are steady, you are in equilibrium. What is imbalance? Imbalance is inability to maintain an appropriate stance in relation to surroundings, and disequilibrium is dynamic. Like the same, during static imbalance, when you are standing, if you are you are wobbling, it is static imbalance. When you are walking, if you are imbalanced, it is dynamic imbalance. So next, what is a vertigo? So vertigo is a different symptom from imbalance. It's an illusion of subjective or objective rotation. So rotation should be there. Everybody tells vertigo, but it is most of the time it is not at all vertigo. So vertigo is an illusion of subjective or objective rotation should be there due to mismatch between visual, vestibular and proprioceptive sensations. That is, when we are standing, you have got a null position adaptation in the visual field so that your seen world is seen with maximum clarity. So if the object is stationary and the patient is stationary, the visual pathway conveys an information to the parieto-occipital region regarding the relationship of oneself to the environment. Vestibular system, we know semicircular canals are there. When there is head tilt, you have got the stereocilia, kinesiocilia, which bend and tell how much your body is angulated with reference to the environment. Proprioceptive is the muscle spindle afferents. They tell how is your neck, and so all these should tell same degree of balance with the environment. Supposing there is a disorder of any one of them, one will convey a wrong information. And when a wrong information is conveyed by an end organ, problem of the end organ, brain will try to correct the vision for tilt, which is not existent at all. So you feel there is rotation. So that is the pathomechanism of vertigo, illusion of subjective or objective rotation due to mismatch between visual, vestibular and proprioceptive sensation. So now we will see what is this vestibular system. We know, I will only give a template because like everything in human body, each topic can be discussed for several janmas. No? And vestibular system consists of semicircular canals. That is for angular acceleration. That is rotatory movement. And utricle is for static tilt. That is linear acceleration. You have got a semicircular canal and you have got a utricle. And semicircular canal is for dynamic rotation and utricle is for tilt. So let us see what are these semicircular canals. We have got a horizontal semicircular. I didn't do it. Yes. I am not. Okay. Inside the copula, we have got the. I don't know what happened. What? So what? So should I start from one? The screen is there now. You are not seeing. Mm. Okay. So we will see the semicircular canals. We have horizontal canal, anterior canal, and the posterior canal. All of us know that. And you have got the copula, and it contains the cilia, stereocilia, and the gynoecilia. And these cilia float in the fluid called endolymph. There is an uniform oscillation during head tilt of the endolymph. And this endolymph oscillation puts the cilia into oscillation. This oscillation is perceived by the vestibular system, and it is carried as a position sense to the central nervous system. So this is the anterior canal, this is the posterior canal, this is the horizontal canal, and this is the utricle, and you have got the ambula part where the cilia are located. So, they sense linear acceleration. So next is the utricle. So utricle is for linear acceleration and semicircular canal is for angular acceleration. And utricle is connected to the superior, connected to the semicircular canals. So these are the semicircular canal, and the end part is the saccule, and beyond that is the utricle. And it contains endolymph. Utricle is for linear acceleration, that is static tilt. And that contains the endolymph. And inside that you have got the otolith organ. This otolith organ is otherwise autoconia. It contains calcium carbonate crystals, which are attached to the hair cells, which I mentioned as the stereocilia and the gynoecilia. So calcium carbonate crystals are attached to the hair cells, and macula is the end organ of that. So these are a vestibular system. When it is deranged, we saw that vertigo. What is vertigo? Is mismatch between visual, vestibular, and proprioceptive input. If the vestibule, due to the shake in the endolymph and the stereocilia and the calcium carbonate crystals giving a long information, gives an information which is different from the visual and the proprioceptive input, the brain tries to correct for the wrong information conveyed by the one of these system, and that results in vertigo. And vertigo is generally, we have defined the vertigo, we have gone through the vestibular system, and when the mismatch happens, vertigo happens, and that should be true rotation. So you ask, what do you mean by dizziness? I feel truly the roof is coming under my feet, that is vertigo, and it is brief and does not last long. So like a psychogenic dizziness, which is there 24 hours, a vertigo is brief and does not last long. It will have a spinning sensation, and it is aggravated by positional change and head shaking. Because as we have just now seen, you have got the semicircular canal with the ambula, utricle, saccule, and they have the endolymph, and inside that fluid column, you have got the cilia, which will shake due to the movement of the endolymph when the head position changes. So you diagnose your dizzy patient has got vertigo. If he has a brief dizziness, it is associated with spinning, and it is aggravated by position change and head shaking. So this vestibular end organ we saw, and we all know that these vestibular afferents go to the vestibular nucleus in the brainstem, and from the vestibular nucleus, it goes to the flocculonodular lobe of the cerebellum, and then this information is processed polymodally in the inferior parietal lobule. So even these structures proximal to the peripheral organ also can produce vertigo, that is central vertigo. Central vertigo is seen in patients with multiple sclerosis, cerebrovascular accidents, use of drugs, alcohol, hypnotics. Whereas peripheral vertigo, you see, we saw that the stereocilia and the gynoecilia is there, and they have got a calcium carbonate crystals, and this calcium carbonate crystal is of a standard weight. So that if you tilt your head 5 degrees, the weight of the calcium carbonate will make an appropriate movement. So that will be translated into 5-degree head tilt by the central connections. Whereas if there is more calcium carbonate getting deposited due to some calcification, then the bend will be, when there is a 5-degree head tilt, the otolith organ will bend 10 degrees. So brain will again correct for a 10-degree tilt, which is not existent there. So that is BPPV. Calcium carbonate crystals of a higher weight sitting on the cilia and bending the hair cells much more. And Meniere's disease, you know that endolymphatic eye drops, where the endolymph becomes poor in circulation and becomes blocked, and that results in the altered oscillation of the stereocilia and the kinocilia. Then you have got trauma. During head injuries, this calcium carbonate get displaced from one cilia into another. And neuronitis or inflammatory disease, where due to inflammation, their flexibility changes. The hair cells become less flexible and they give wrong information. And the drugs which can affect the functioning of this vestibular system, they also lead to peripheral. So peripheral causes are in the vestibular system, central causes are in the brainstem and the cerebellum. So what is the clinical features of a central vertigo? Very important to recognize, because if you miss a central vertigo, next day patient will end up with a brainstem stroke and we would have lost the valuable window period. So central vertigo produce gaze-evoked nystagmus. Gaze-evoked means when you are looking to the right, the fast component of the nystagmus is the right. When you are looking to the left, the fast component is the left. When you look up, the fast component is up. When you look down, the fast component is down. That is a leaky neural integrator. That indicates cerebellum is involved. Or it can be uniplanar, because we know that the vestibular nucleus has got 4 subcomponents, and each one nucleus can be individually affected, in which situation you can get a uniplanar nystagmus, that is downbeat, upbeat, like that you can get. And this nystagmus is localizing to the cerebellum, but it does not localize to the side of the disease. And the nystagmus is always present and there is no latency, fatigability or adaptability. So the nystagmus remains like that. And fixation, when you fixate on an object, the nystagmus becomes worse. And there can be additional features of brainstem involvement. And it can be of mild to moderate severity only. The vertigo in these central cases is mild to moderate severity. Whereas in the peripheral vertigo, the nystagmus is localizing. That means the nystagmus has got a slow component which is always to the side of the disease. Supposing the right vestibular system is affected, whether you are looking to the left or right, the slow component of the nystagmus is to the right side. And there is a latency in the appearance of the nystagmus, and when you repeatedly do, it fatigues and adopts and goes away. That does not happen in the central nystagmus. And patient is usually comfortable lying with the affected ear up. There is no such preferred side for the central vertigo. And fixation, when you fixate, unlike the central nystagmus which gets aggravated, peripheral nystagmus gets suppressed. And there can be, unlike the brainstem features in central vertigo, in peripheral vertigo, patients can have deafness or tinnitus. And peripheral vertigo is the worst type of vertigo compared to the central vertigo. So now we will see one by one. BPPV is a very common condition. It is benign, it is positional, it is paroxysmal. So the term itself says it's a benign condition. Unlike the central vertigo, it doesn't carry a grave prognosis, but it is alarming to the patient. It is paroxysmal and positional. So benign, positional, paroxysmal vertigo. The term itself is self-explanatory. So it depends on the position. When the position changes, the vertigo becomes manifest. That is positional. Benign because it is not dangerous, and it is episodic, so paroxysmal. It is not always present. And there is a poor response to labyrinthine sedatives, because what happens is not in the vestibular nerve end organ, but it is inside the hair cells. The pathology is in the hair cells of the utricle, so it doesn't respond very much to labyrinthine sedatives. And examination may not reveal either brainstem features or END features. So no features will be there. And it starts with a latency and lasts less than a minute. When you change from one position to another position, there is a few milliseconds before the vertigo manifests, and it will subside within 1 minute. When you adopt a new position, within 1 minute, the vertigo stops. And if head is turned backwards, the vertigo occurs in the opposite direction. So when you get up and sit down, it is coming with a latency and lasts 1 minute. And tell the patient to turn his head backwards, then it appears in the direction opposite to the initial direction. And after the head has stopped moving to the otolith drags endolymph, because the calcium carbonate crystals are heavier, displaced or calcified. So even after the head has stopped moving, it is positional. So when you move the head only, it is appearing. But after the head has stopped moving also, because of the weight of the calcium carbonate that is deposited in the hair cells, the otolith drags endolymph. Therefore, when the otolith drags the endolymph, the receptors start firing and making an illusion that head is moving. That is the mechanism. It is benign, paroxysmal, positional, lasts less than 1 minute. It has got a latency. Why it happens? When the head has moved, true, it moved. But after it stopped moving, the otolith, because of the heavier nature of the calcium carbonate in this condition, it drags the endolymph. When it drags the endolymph, the receptors continue to fire instead of stopping to fire. And therefore, there is an illusion that the head is moving. So that is the mechanism of benign paroxysmal positional vertigo. So what happens exactly? The otoliths becomes detached from the hair cells in the utricle. So you have got the hair cells. On top of it, the calcium carbonate is there. Due to various causes, head trauma or infections or violent sneezing, these otoliths become detached from the hair cells in the utricle. Inappropriately, it enters into the posterior semicircular canal. These calcium crystals get detached from their location and they enter into the posterior semicircular canal. So that is the mechanism. Next, vascular causes. No? So supposing you have got a brainstem migraine or a TIAs, then what happens? This vertigo, unlike the BPPV, which lasts less than 1 minute, it lasts for hours. So vascular cause for the vertigo is usually central and it lasts for hours, 2 minutes, not less than 1 minute. Doesn't disappear within 1 minute, it lasts. And there can be brainstem features like double vision, altered speech, swallowing difficulty, weakness and numbness during that period. If there is a followed by headache, this can completely improves and the person is young, not having any other risk factors, and it is recurrent, it could be a brainstem migraine, which is called Bickerstaff migraine. And it is recurrent, but it is reversible. It is seen in young persons, and headache may or may not be present. So young person, no comorbidities, repeatedly happening, then we think it may be a vertebrobasilar migraine or Bickerstaff migraine. So that they will have vomiting, all those features, and the treatment for this condition is to treatment of the migraine. Then vestibular neuronitis. It is recent, comes very short duration. The vertigo will be very severe and it will be several episodes. Unlike the positional vertigo, which is only due to position change, or vascular causes which are episodic, last longer. Here it is recent, severe, and several episodes happen. So patient will be severely sick with vertigo and vomiting because it is due to permanent change happening due to infective inflammatory cause, and it has to subside, usually treated with steroids with or without antiviral and antibiotics. That is vestibular neuronitis. Then you can have psychiatric conditions, panic attacks that will be associated with sweating and palpitation. And patients with multiple sclerosis, vertigo is preceded by other neurological dysfunctions like optic nerve involvement, brainstem involvement, spinal cord involvement, etc. Then acute and chronic alcohol abuse. Alcohol acts on the acute alcoholism acts on the flocculonodular lobe, and chronic alcohol acts on the paleocerebellum. So these both organs are concerned with the balance. So the patient becomes dizzy irrespective of whether he is having an acute alcohol or a chronic alcohol abuse. Then you have got other hereditary and familial disorders which the patient might describe as dizziness. So spinocerebellar degeneration. When they start, the signs are very subtle, but patient is subjectively impaired. And when you When the patient's disease becomes more severe only, we may be able to demonstrate all the features of skeletal abnormality, areflexia, cerebellar signs. But initially, patient feels a vague feeling of discomfort, so he might call it as a dizziness. And you have got olivopontocerebellar atrophies. Then you have got hereditary neuropathies, where there is sensory deafferentation. So proprioceptive, we saw the vestibular input, central and peripheral. Now we have got the proprioceptive input due to the peripheral neuropathies, where that is one of the three: visual, vestibular, and proprioceptive. So neuropathies, they deprive the central system of the proprioceptive input, so the patient feels dizzy, unable to judge his relationship to the environment. Other situations of concern where the patient might initially present with dizziness is atypical Parkinson's disease, where patients can have postural hypotension. They can have trunk imbalance. No? Then subacute combined degeneration, where the posterior column and the corticospinal tract degenerates. Because of the posterior column degeneration, they may not be getting the proper sense. And multiple sclerosis, where multiple systems, cerebellum, vestibule, spinal cord, all of them get involved. Craniovertebral junction anomaly, where the flocculonodular lobe will descend due to Arnold-Chiari malformation. And like the subacute combined degeneration, corticospinal and posterior column becomes affected by compression. And posterior fossa tumors, where the cerebellum becomes directly or indirectly affected. So these are other grave causes for dizziness. Then, so these are the various causes. So we are when a patient comes, we will have to ask some questions. So we saw it is a true rotation, that is vertigo. So if a person comes with a dizzy complaint, you ask, is it a true vertigo or is it a vague, ill-defined symptom which he calls as dizzy and not true vertigo? If it is true vertigo, we saw the central and the peripheral vertigos. Applying that template, we can decide what it is. If it is not a true vertigo, then go to find out the other causes. We saw the drugs, alcohol, sensory, psychogenic. So any one of them could be the cause. So is it true vertigo or not? That's a very pertinent and a very vital question to be asked. After that, any associated neurological symptoms are there. So you have to ask the patient whether he felt numbness through one half. That you would have forgotten in the alarm of the vertigo. Vertigo is a very alarming symptom. So patient would have not noticed the transient sensory symptom which happened, which will point to a central dysfunction. In the onset, whether it is acute, subacute, chronic, we saw the various peripheral things which last for a very short period, and the vascular syndromes which last for minutes to hours, whereas psychogenic, they last for persistent. The psychogenic symptoms are persistent. Drug-induced, alcohol-induced symptoms are persistent. So ask whether the patient has got any ENT features. And is the symptom continuous? If it is continuous, you have to think of either permanent neurodegenerative disorders, psychogenic disorders, drugs, alcohol. If it is intermittent, the peripheral conditions are all intermittent. What is the duration? Vestibular neuronitis is very short, new onset, brief. Whereas many are and other ENT causes are long duration and they are intermittent. So these vital questions have to be asked to find out what is happening to our patient. So then how are you going to understand labyrinth? We saw these are viral infections. We say vestibular neuronitis when only the vestibular symptom is there. When the vestibulocochlear symptom is there, you call it as labyrinthitis. Both happens due to the same inflammatory infective causes and unilateral loss of peripheral vestibular dysfunction. It is unilateral. Usually, both vestibular system or both the labyrinth do not get involved together. So it is usually unilateral vestibular dysfunction. They will have vertigo and nystagmus. And it is worsened by head movement because the vestibular system, we saw how the endolymph and its oscillations influence the phenomena. So worsened by head movement and usually preceded by some viral infections. So when there is a combination of cochlear and vestibular, you call it as labyrinthitis. If there is no cochlear, you call it as vestibular neuronitis. Next is Meniere's disease. It's a familiar condition. It has got the triad of vertigo, tinnitus, and hearing loss. It is familial and it has got a chronic relapsing course. And due to the buildup of endolymphatic pressure in the labyrinth. So the patient feels a feeling of fullness in the ear and they can have a dull pain. So feeling of fullness and a dull pain in the ear running in families, usually middle age or late middle age, with the triad of vertigo, tinnitus and hearing loss is Meniere's disease due to building up of endolymphatic pressure inside the labyrinth. Then the vascular causes vertebrobasilar circulatory events like transient ischemic attacks or strokes. Then it can be cerebellar infarction due to ICA, superior cerebral artery, pica, or the vertebral artery, or the major basilar system itself. Then pica syndrome is the lateral medullary syndrome or the Wallenberg syndrome. And dissection of the vertebral artery. When you have a dynamic injury, getting down from a running train, then it's the vertebra gets stretched and the vertebral artery which goes through the vertebra gets dissection, goes into dissection. That will result in the brainstem strokes. So these are vascular causes. Then we have got a perilymphatic fistula induced by trauma. So traumatic fistula at the round or the oval window. It is usually produced by coughing, sneezing, diving or other injuries. And recurrence of vertigo with pneumootoscopy. When we do the pneumootoscopy, the patient gets vertigo. That indicates that there is a fistula in the round or the oval window. So now when a patient is complaining of dizziness, so we will first ask, that's what I have told now, on the true vertigo or no true vertigo. So if there is a true vertigo, is there any associated neurological symptoms and signs? If it is not there, it is generally ENT cause. And so if it is there, then you think of a neurological cause like a brainstem disorder. So is it a true vertigo? And if it is a true vertigo, is it associated with the brainstem features? Then it goes to the central cause. If it is not associated with brainstem features, goes the peripheral cause. And the peripheral cause, if the auditory symptoms are not there, it may be BPPV. Because the auditory nerve doesn't get affected in BPPV, it is only the flow of the calcium carbonate from the utricle to the semicircular canal. And then if it is auditory symptoms, if they are present, it may be Meniere's disease, it may be labyrinthitis. Then if there are associated brainstem symptoms, you ask whether there is head injury or whether there is any fever. So if there are head injury, it can be traumatic dysfunction or it can be fever, it can be infective, inflammatory. So we have to investigate the patient accordingly. And if there is a head trauma, then it could be due to trauma-induced temporal bone fracture, intracranial hemorrhage, ICP, concussion-induced labyrinthine dysfunctions, all those things. So that is the flowchart, true vertigo or no true vertigo. And what about the brainstem signs and no brainstem signs? And if there is trauma, what are all the structures that are affected? If there is no trauma, is it infective, inflammatory, demyelinating? So this is the flowchart we generally follow. So how are you going to evaluate this dizzy patient? We have seen the proprioceptive, visual, vestibular, psychogenic drugs, all those causes which could make the patient dizzy. Then your complete history and physical examination, keeping all these features in our mind, and thorough neurological assessment and ENT assessment and dizziness simulation battery. So continuous head oscillation. So some precipitating things are there, telling the patient to hyperventilate or putting a pressure on the external auditory canal. So various kinds of dizziness can be unmasked by dizziness simulation battery. And then we have got the laboratory investigations like multiple sclerosis. If you suspect, you can do the auditory evoked response. Auditory neurofibromas, you can do the evoked responses. Multimodal evoked response if you are thinking demyelination. And if you are thinking of a posterior fossa tumor, degenerative disease, you have to do the imaging and the peripheral nerve conduction studies. So those are the laboratory evaluation. Then evaluation contains detailed description. That's the most important thing. Detailed description of the patient's experience. That is most vital. Then vertigo or non-vertigo, associated auditory symptoms, acute, chronic or recurrent, and neurological symptoms and signs, and past and current medications. Then key points in the physical examination, look at the vital signs, look for bruit in the for vertebrobasilar aneurysms, AVMs, and ENT examination, eye examination, and position testing, and neurological examination, including gait. Then we will come to the other systems. A dizzy person may be suffering from cardiac disease. They may be having a vasovagal pre-syncope, obstructive cardiomyopathies, cardiac arrhythmias, carotid sinus syncope, orthostatic hypotension due to volume depletion, drug-induced volume depletion or drug-induced labyrinthine and cerebellar dysfunction, autonomic dysfunction, severe anemia resulting in hypoperfusion. So these are the other system causes which also we should keep in our mind. The non-specific dizziness, none of these things are there. Neither the neurological, nor the ENT, nor the systemic diseases are there. The non-specific dizziness, psychiatric disorders. Major depression, 25% of the patients present with dizziness. General anxiety or panic disorder, 25% patients present with dizziness. Somatization disorder and alcohol dependent syndrome. Personality disorders. All and hyperventilation syndrome, all overlap with pre-syncope. That can happen with coronary artery disease, congestive heart failure, autonomic disorder. With the second, yes, ma'am. Now is it audible? Okay. Non-specific dizziness is uncharacterized. We have gone through the various disorders from the minor ones to the major ones. So non-specific dizziness, neither the minor nor the major disease you are finding. Then think of depression, anxiety, panic disorder, somatiform disorders, alcohol dependence, and personality disorder patients who complain of dizziness, which is not having a either peripheral or the central cause for the dizziness. Then hyperventilation syndromes. People habitually hyperventilate in response to stress. They wash out carbon dioxide, resulting in intracranial symptoms in the form of dizziness. And it could be an overlap with the psychiatric versus organic. So patient may have heart disease or cardiac arrhythmias. They can have autonomic dysfunction. Even though that is very mild, additional psychiatric symptom overlap produces more severe dizziness. So that we have to remember. Then what is this Dix-Hallpike maneuver? That is we saw that the calcium otolith escapes from the utricle to the posterior semicircular canal in benign paroxysmal positional vertigo. So how to demonstrate that? You have to, patient is seated upright facing the examiner. Then the patient can grasp the examiner's hand and for his stability. Then the patient is moved rapidly into the supine position with the head extending just beyond the examining table. So the head hanging position. The head will go beyond the examining table and it is turned to the right side. And then you look for the signs of vestibular dysfunction in the form of nystagmus with a brief latency, lasting short duration, fatiguing easily, and reverse nystagmus on upright position. So these are the features of BPPV that you demonstrate by Dix-Hallpike maneuver. So patient sits erect, then suddenly the examiner grasps him, turns his head to the right side, brings it below the edge of the table, goes to the head hanging position, turn to the right side, and look for nystagmus, brief latency, short duration, and fatigability. and reversal of nystagmus on upright posture that clinically confirms patient is suffering from BPPV. So that is one test. Other test I mentioned, I have not included all those charts and evoked responses because it is mainly a clinical approach to the disease portion. So if you think it is vertigo, we have seen various causes, you treat the underlying cause. So what caused the, if it is Bickerstaff of migraine, treat the migraine. If it is multiple sclerosis, treat the multiple sclerosis. If it is vertebrobasilar ischemia, treat the CVA. If it is cerebellar tumor, treat the tumors. Meniere's disease, it is endolymphatic hydrox. So reduce the salt intake and use diuretics. Vestibular neuronitis or labyrinthitis, usually viral, sometimes bacterial. So antibiotics, antiviral and steroids along with symptomatic medication. BPPP, as it does not respond to the labyrinthine sedatives, we have to use the particle repositioning maneuver. So we have seen that the particle escapes from the utricle to the posterior semicircular canal. So that has to be repositioned. So how are you going to do that? That is by the Epley maneuver. To demonstrate BPPV, we do the Dix-Hallpike maneuver, and to treat it, we use the Epley maneuver. That is otherwise called canal repositioning maneuver. So moves otolith out of the posterior. So that is aimed at removing the otolith out of the posterior semicircular canal and back into the utricle. It has moved from the utricle to the semicircular canal, so push it back to the utricle. So repeat that Hallpike maneuver, which we just now seen how to do it. So repeat that Hallpike maneuver. Then after you have reached the patient to the right lateral position with the Hallpike maneuver, then turn the head 90 degree in the opposite direction. And then made to roll onto the shoulder and look down at the fold. So now the patient is, he has undergone the Hallpike maneuver. He is in the right lateral position. Suddenly tilt his head 90 degrees in the opposite direction. Then turn him over to his shoulder and tell him to look down position and then come back to upright position and remain in that for 8 to 24 hours. So that is the maneuver used to push back the otolith from the semicircular canal into the utricle. So I think people understood. The person is told to repeat the Dix-Hallpike maneuver, then turn the head 90 degrees in the opposite direction, and then tell the patient to turn over on the shoulder, look down at the floor, then pull up straight and remain like that for 8 to 24 hours. But it needs caution. So even though BPPV does not respond to labyrinthine sedatives, many of us do not do this maneuver. Patients with heart disease, they can develop arrhythmias, hypertension. People with carotid stenosis, they can develop strokes. And degenerative neck bone disease, they can develop myelopathies and cervical disc prolapse. TIAs and strokes can be precipitated. And patients beyond the age of 24 weeks of pregnancy, this is not safe to perform. So then pharmacotherapy, vestibular suppressants. So that the wrong information, we thought that it is mismatch between visual, vestibular and proprioceptive input. So we cut off the person who is giving the wrong signal. So vestibular suppressants, meclizine is the most commonly used H1 antagonist. It can significantly reduce the symptoms which are sent by the wrong information from the vestibular system. Dimenhydrinate and diphenhydrinate and promethazine, prochlorperazine. These are some of the drugs which reduce the input from the vestibular system. So central cause, we have to, other conditions, each one of them is treated according. Yes, yes. Am I audible? Anyway, I have reached the last one. Yes, careful history. Careful history. Yes, yes, it is raining here. So careful history, which I have gone through. It's a very long, one or two PPTs only. I will finish it off. So it's a take-home message. What I am telling is it's a simple topic. It's not a complex topic. It's a complex symptom, a simple common symptom, but sometimes difficult to give an answer. So I have gone through. So careful history is very important, and dizziness could get worse if left untreated. If it is due to organic disease, and dizziness increases the risk of falling. So falls can lead, rather than the dizziness, falls can lead to problems, and dizziness makes it unsafe to drive vehicles, and dizziness thus affects quality of life. So we have to take a proper history, see whether it is peripheral or central, is it due to a major disease or minor disease, and sort out as it's psychiatric condition, non-organic, all of them should be sorted out so that your disease patient becomes put into a channel template and guided properly. So thank you. Yes. Thank you. Thank you.